This PowerPoint is over dentin and pulp, and I'm going to start with the dentin. The dentin encloses the pulp and is covered by enamel in the crown and cementum in the root of the tooth. It is 70% mineralized, so that makes it the second hardest tissue in the body. We have enamel that's 96% mineralized, which is the hardest tissue in the body. Then we have cementum, which is 65% mineralized, and then alveolar bone, which is 60% mineralized. The dentin is composed primarily of collagen fibers and hydroxyapatite mineral crystals, which that is our Ca10PO46OH2. Those crystals are about 30% smaller in the dentin than they are in the enamel. Dentinogenesis, or the apposition of dentin, occurs throughout life. There are about 4 micrometers of pre-dentin laid down daily, and there are odontoblasts that remain at the outer pulp wall throughout life. So the apposition of dentin starts with pre-dentin, and it lays down a dentin matrix, and then throughout life it continues to lay down a secondary dentin matrix. There are 2 steps in the maturation of dentin. There is primary mineralization and secondary mineralization. Now, dentin is resilient and slightly elastic to withstand the impact of mastication. It has great tensile strength to support the more brittle enamel underneath. The primary dentin is the major component that forms the body of the tooth, or the body, most of the dentin. There is the mantle dentin, which is the larger collagen fibers that are more towards the coronal portion, or more towards the DEJ of the tooth. Then we have globular dentin, which is disturbed dentin formation. It might be a little more deficient in mineralization. It is usually found only in the crown of the tooth, but it can sometimes be formed or found in root. Then we have the circumpulpal, the fibers in the circumpulpal, which circumnavigates the pulp, are about 10 times smaller than those in the mantle. So of course it makes sense that the fibers would be bigger towards the outside and smaller towards the inside. The secondary dentin is a narrow band of dentin that borders the pulp. This dentin is formed when the teeth are functioning. This is the dentin that is formed throughout life. Globular dentin exists where primary and secondary mineralization have occurred with complete fusion of the crystals. Odontoblasts, which are our dentin-forming cells, form dentin. First, they form pre-dentin, which borders the pulp and is calcified within about 24 hours of the collagen matrix formation. First, globules are formed within that collagen matrix, and that allows for both the expansion and fusion during the primary and secondary mineralization period. On this slide, you can see the pulp at the bottom and the odontoblasts, which are our dentin-forming cells, which are located at the outer pulpal wall area, forming the pre-dentin first, and then the globular mineralization, and then the mineralized dentin. Interglobular dentin contains hypomineralized spaces between the calcified globules. It is noticeable more in someone with a vitamin D deficiency. Dentin tubules run without interruption through that area, indicating a defect in the mineralization, not in the matrix formation, just in the mineralization. So you'll see some voids or some defects in the mineralization. In this picture, you can see the globular dentin, and then you can see the interglobular dentin, where there are voids in the mineralization, but not in the formation. Dentin is a vital tissue because it has living components in it, but it is avascular. Nutrients for the odontoblastic processes, which are our dentin-forming cells, or the extension of our dentin-forming cells, come from the blood supply from the pulp. Dentinal fluid inside the tubules is tissue fluid and surrounds the odontoblastic processes. In mature dentin, the odontoblastic processes may not extend all the way to the DEJ or DCJ, so dentin enamel junction or dentin cemento junction. In this picture, you can see the pulp at the bottom, and then the odontoblasts, which are our dentin-forming cells, and then the odontoblastic processes, which are in the dentin tubules, and they do not extend all the way in most cases from the DEJ, DCJ to the pulp. In primary dentin, which is the major component that forms the body of the tooth, there's an overall S-shaped curve within the dentin tubules. In the secondary dentin, which forms throughout life and is closer to the pulp, there are much smaller curves within the S. The curves make the dentin resilient and supportive to help keep the brittle enamel from fracturing. There is less curves, or are less curves, in the root dentin of a tooth. Dentin tubules can branch and are more frequent with branching in the root surface, and there is some anastomosis. Remember how we talked about anastomosis with nerves and blood supply? There is some anastomosis where some of those odontoblastic processes are connected, and bacteria and decay or caries can spread through those anastomosis of the connected odontoblastic processes. If you look at this picture, you can see the odontoblast, which is our dentin-forming cell, in the first layer of predentin near the nerve of the tooth, and then we've got our intertubular dentin and our peritubular dentin around the dentin tubule, our intertubular between the dentin tubules, our interglobular up towards the mantle dentin, and then our DEJ at the top with that last little process sticking out there where the dentinal tubule would be in the cervical area most of the time. You can see the little secondary tubules where the odontoblastic processes are connected. If you had decay that got in through the enamel, so incipient decay spread across the DEJ, and now it's into the dentin, which is less mineralized to begin with, it can spread quickly because it almost follows those odontoblastic processes like a chute towards the center of the tooth. And as it follows it, it kind of goes off on those little branches so it can spread and progress very quickly. This is a list of the different types of dentin. I just talked about the peritubular being around the dentin tubules and the intertubular being between the dentin tubules. Those are both highly calcified areas of dentin. We have the mantle dentin, which is the outermost layer of the dentin. That is the first dentin formed, and that is more coronal in the tooth. We have the circumpulpal, which circumnavigates the pulp of the tooth. That's the layer that's right around the outer pulp wall, and that's formed after mantle dental. We have the primary dentin, which is formed, that's the bulk of the tooth, that's the bulk of the dentin in the tooth. That is formed before completion of the apical foramen. So that's formed when the tooth is finishing forming. That's formed more rapidly and is more mineralized. Then we have secondary dentin, which is formed after completion of the apex on a tooth. That is formed slowly, that's less mineralized, and that's the kind of dentin that is formed throughout life that is very close around the pulp. Then we have tertiary or reparative dentin, which is formed as a result of an injury. So there's an irregular pattern of formation of that tertiary or reparative dentin in response to an injury. You can see a picture of the peritubular, which is around the dentin tubule, and then the intertubular dentin, which is between the dentin tubules. And we've got our little secondary connections there, our anastomosis, where if you had bacteria that got into the dentin of the tooth, which the dentin of the tooth is less mineralized to begin with, but it could go right down that dentin tubule towards the center of the tooth, and it could spread through these secondary channels through anastomosis and quickly progress throughout that second layer of tooth, that dentin. With dentin, you can see in this picture, again the same picture, but this is the odontoblast, and it forms the matrix first, the predentin, and then it mineralizes. Now, with the dentin tubules, you can see that they're smaller in diameter in the outer dentin. So when we look at the DEJ at the top, the mantle dentin, they're smaller, and then they get larger as they go towards the pulpal border. Odontoblasts increase in size as odontoblastic processes grow in length. Now, there is something that's called sclerotic dentin or transparent dentin. That is when the tubules of the dentin are completely obliterated. So you can have sclerotic or transparent dentin where the tubules are completely obliterated. Here's a picture showing the mantle dentin that is towards the outside or the coronal portion under the DEJ in the crown of the tooth. And then circumpulpal, which is circumnavigating the pulp, which is closer to the inside. The mantle dentin is typically your primary dentin that forms the body of the tooth. The circumpulpal forms right around the pulp, and that is where your secondary dentin would continue to form throughout life. Again, our list of peritubular, which makes up the walls of the tubule, intertubular between the tubules, which are highly calcified, mantle, the outermost layer, circumpulpal, the innermost near the pulp, the primary dentin, which is formed as the tooth is forming before the apex is complete, secondary formed throughout life after the completion of the apex, and then tertiary or reparative formed as a result of an injury. You can see here's the primary dentin, which is away from the pulp, and then the secondary dentin that borders the pulp. So this is obviously a picture after the apex has formed. Here is a picture of reparative dentin. So right at the first initial border where that line is the secondary border, and then reparative dentin has been laid down by the odontoblasts that have been stimulated to protect the pulp of the tooth. So reparative or tertiary dentin are laid down when there is an assault or injury to the tooth and the tooth is trying to recover. Secondary dentin is formed on the entire pulpal surface after the apex is formed and throughout life. Tertiary or reparative dentin are formed only in one area in response to disease or trauma when the odontoblasts have been activated. There are some microscopic features of mature dentin that we will see. There is something called imbrication lines of von Ebner. These are similar to lines of Retzius in enamel, and they run at right angles to the dentin tubules, and they represent a rhythmic apposition of dentin. These lines will indicate a hesitation in the matrix formation. So on this next picture, you can see where these lines are, there's just a little bit of a hesitation where it's not a complete smooth mineralization, but there was some type of hesitation in the formation. There are also contour lines of Owen. Those represent a disturbance in body metabolism that affects the odontoblast. The neonatal line, which is the line that is pronounced because that's when the birth process happened, neonatal line, that's what happens at birth. That is a very pronounced line of Owen. So the line of Owen represents a disturbance in body metabolism that affects the odontoblasts, and the lines of von Ebner indicate a hesitation in matrix formation. This picture shows, with the enamel on the outside and the dentin layer on the inside, it shows that definitive line that the arrows are pointing at. That is our line of our neonatal line. All of the rest of the right angles there are the lines of Owen, and that line of Owen that is more pronounced is specifically the neonatal line, which was because of the disturbance in metabolism at birth. There is a Tomes granular layer that is found in root dentin just deep to the cementum. It's thin and hypomineralized, and it is most likely due to the odontoblast looping before they went towards the pulp. So this is of clinical significance. And in this next picture, you can see the dentin and the cementum, and this is on the root surface, and that Tomes granular layer. It kind of looks like there's some granules in that picture. Now, as people age, there are changes in dentin. The diameter of the dentin tubules narrow, and some of those tubules become completely mineralized. We talked this week about dentinal hypersensitivity and how our 18 to 44-year-olds are the most sensitive patients that we have. And there's lots of products that we have to look at for sensitivity as far as potassium nitrate in a sensitive toothpaste, stannous fluoride, sometimes even some other products. As people age and they have more root exposure, which you would think they would be more sensitive, they actually are less sensitive because those tubules become mineralized or they narrow just with age. Another thing that we were talking about is we can have abrasion, which causes root sensitivity and the dentinal tubules to become more microscopically exposed. So we talked to somebody about mechanical measures and, toothbrushing and that kind of thing. There are erosive things that people do to chemically make teeth sensitive or dentin tubules more open. And then we have attrition. Now, attrition is tooth-to-tooth contact, and we typically will see attrition on the lower anterior on an older person. And when there is attrition, there can be a thin covering of enamel, but enamel is pretty translucent. So when you get a very thin layer of enamel, then the dentin is going to show through a little bit more, which we can obviously see on the incisal edge when somebody has attrition. But even with just recession in general or abrasion, we can see through the more translucent enamel, and it gives the teeth a darker look or a more yellow look, which the older patients don't like, and they often talk about wanting to bleach. Now, if we go back to the structure of the dentin and kind of those S curves, and if we think about how the dentin tubules go through the dentin, the pattern and the spread of caries can progress very quickly in the dentin. The dentin is only 70% mineralized, so it's less mineralized than enamel. Once we get a lesion or bacteria that goes through the DEJ, it starts out as incipient decay. And then once it gets through that DEJ, it can spread very rapidly. The bacteria can destroy the dentinal fibers and go towards the pulp, and then it can spread through those secondary channels that we were talking about through the anastomosis. And it's lower mineralization, and there's anastomosis of those dentin tubules. So once the decay gets past that DEJ, we have to do something about it, and the earlier we find it, the better, because it can spread quickly. Now, progress of caries is slowed but not stopped by tertiary dentin. Once the decay gets through the DEJ and it starts to spread throughout the mantle, globular, and circumpulpal dentin, the odontoblast will be signaled to lay down tertiary or reparative dentin. Now, it will slow down the progress, but if the decay is not taken care of, then it will not stop the process of the decay going towards the nerve of the tooth, and then that tooth ultimately dying because the tooth can't protect itself anymore with the tertiary or reparative dentin. We talked a lot about dentinal hypersensitivity in clinic class this week, and we talked about the hydrodynamic theory, how the fluid is moving in and out of those microscopic dentin tubules. Air is moving in and out and can cause some of the fluid, just the saliva in the mouth, to move in and out. And we also talked about blocking those tubules with stannous fluoride, with potassium nitrate, with something. Just the structure of the dentin tubules being open at the CEJ is significant with dentinal hypersensitivity. Often after a restoration, there will be some sensitivity. There will be some sensitivity as the tooth is recovering and tertiary and reparative dentin are being formed. The pain should go away or should be getting better and subside after a few weeks once the formation of that tertiary or reparative dentin is complete. So it is normal to have some sensitivity after a restoration is done. I am going to continue talking about the pulp. Now remember, the tooth germ has the three different parts: the enamel organ, which enamel comes from the enamel organ, then the dental sac, which gives us the PDL, cementum, and alveolar bone, and then we have the dental papilla, the DP, that gives us the dentin and the pulp. So the pulp comes from the dental papilla part of the tooth germ, and it is mesoderm. It's connective tissue and not nerve tissue. So pulp functions are support, maintenance, and continued formation of dentin. There are sensory functions. It will feel the pain sensation. It's pain only. It doesn't matter if it's hot, cold, sharp, whatever. It distinguishes everything as, it doesn't distinguish things individually. It takes everything in as pain. There are protective functions. The pulp is involved in the formation of secondary or tertiary dentin. Remember early on that the pulp has a lot of different functions in the formation of things. So it's inductive in the early stage. The papilla and pulp interact with oral epithelium and induce tooth formation. It's formative in the fact that odontoblasts of the pulp form the dentin that surrounds and protects the pulp. And then we get into the protective stage where, in response to stimuli, sclerative dentin is formed and deposited in the minerals in the dentin tubules. And then we have the reparative part where, through response to trauma or caries, the pulp forms reparative dentin to protect the pulp. We're going to see a picture on the next slide of what the tooth looks like and where the pulp is located. But there is a pulp chamber. There's a coronal pulp, which is within the crown of the tooth, that has pulp horns that correlate with the cusps of the different posterior teeth. And then there's the radicular pulp, which is in the root structure that extends from the cervical area, or the CEJ, to the apex of the tooth, and that includes the apical foramen and sometimes accessory canals that might be present. 85% of root canals work and do really well, and then there's this 15% that are just never right, and that could be because of accessory canals, or because that the endodontist doesn't find, or because of a crack somewhere in the tooth. Within the pulp structure, the two most prominent cells are the fibroblasts that form connective tissue, and then the odontoblasts that form dentin. Those odontoblasts are along the border with dentin in the crown of the tooth. Here's the picture that shows the coronal pulp, which is in the crown of the tooth, and then the radicular, which is in the root surface. And then it also shows that accessory canal. Shows the pulp horns, which are kind of raised within the crown of the tooth. I mentioned that the fibroblasts are the most numerous cell in the pulp, which fibroblasts form connective tissue, and then odontoblasts, which form dentin, are along the border with the dentin within the crown of the tooth. But other cells that are in that pulp include endothelial cells, red blood cells, white blood cells, macrophages, mast cells, monocytes, leukocytes, lymphocytes, mesenchyme, histocytes. There's a vascular system where there's a blood supply, so it is vascular versus avascular. There's nerves. There's lots of collagen and reticular fibers, tissue fluid, intercellular substance. So the pulp has a lot of substance to it microscopically. Pulp stones, otherwise known as denticles, can be present within the coronal pulp area. We can have true pulp stones that are calcified masses of dentin that have tubules and processes, or we can have false pulp stones which are calcified but there's no structure to them. These denticles or pulp stones are masses of dentin within the pulp. It makes sense that this could happen because the odontoblasts line that outside area of the pulp. So if there's any disturbance, there can be dentin that's deposited in a different area within the pulp. They can be attached to the dentin pulp complex, or they can be unattached. They can be embedded in the dentin. They can be iatrogenic, which is clinician induced, or natural. They can be formed during tooth development. they are more frequent as the pulp ages. So as someone gets older, they're more likely to have a pulp stone within that pulp area. Here's a picture of pulp stones or denticles. You can see in the tooth on the right that there are two areas where there's masses of dentin within the pulp, so two denticles or pulp stones. There are 4 regions visible in a young mature pulp. There is the, going from the outer to the inner zones, there's the odontoblastic layer that has the most nerve endings in the odontoblastic area. This is a layer that lines the outer pulpal wall and consists of the cell bodies of odontoblasts. Secondary dentin may form in this area from those odontoblasts. Then we've got the cell-free zone. This is the zone of Wheel, W-E-I-L. This is a cell-free zone, which is a narrow layer between odontoblasts and the pulp. Then we have a cell-rich zone, which has an increased number of defense zones before we get to the pulpal core, which is the central core of connective tissue. A mass of pulp, blood, and lymphocytes is present in the pulpal core, the center of the pulp within the crown. Here's a picture that shows the zones that we just described. We've got the odontoblastic layer on the outside, closest to the dentin, furthest away from the pulp. That's an area where throughout life, secondary dentin is going to be formed from that odontoblastic area. Yes, in the beginning it forms dentin and, initiates the formation of enamel through the ameloblast and all that we've already talked about. But a function of a tooth pulp in general is the production of the secondary dentin to protect the tooth throughout life. Then we've got the zone of Wheel, the cell-free zone, which is the narrow layer between the odontoblasts and the pulp. Then we've got the cell-rich zone that has increased number of defense cells. And then we've got the pulp core in the middle, which is the central core of connective tissue, or that mass of pulp, blood, and lymphocytes in the very center. Another microscopic picture that shows the outside odontoblastic layer that is nearest to the dentin, then the cell-free zone, where there's that narrow layer between the odontoblasts and pulp, then the cell-rich with the increased number of defense cells before we get to the pulp core. As the tooth ages, the pulp decreases in size with continued deposition of dentin. The function of the tooth pulp is production of secondary dentin throughout life. That's the most important function of the pulp. Pulpal cells decrease in general, cell activity decreases, aging decreases the pulp's ability to respond to injury and repair itself. Hopefully by the time somebody gets a little bit older, they are coming in regularly, they're taking x-rays regularly so that we can catch things when they're small before it would get to the pulp, because there's a lot of stuff that it has to go through between the secondary dentin, reparative dentin, and the pulp shrinking in size. There's a lot of tissue it has to get through